The 10 tips and tricks to do infratubercle slope change osteotomies. This is the disclosure of the authors. First, how to plan. We always plan on long X-ray to avoid any underestimation of the slope because of the distal curvature of the tibia when looking at long X-rays. Second, the key wires need to be positioned for the first one, the more proximal one, 2 to 3 centimeters from the more proximal aspect of the tubercle. Then, based on the angle measurement, we always measure the resection height on calipered X-rays. Second, how to position the patient. You need to take into consideration that you need a fluoroscopic devices, putting both in frontal and lateral views. Second, you need an arthroscopy system, and then being able to harvest graft both on distal aspect of the leg and potentially perform a lateral tenodesis. An anteromedial approach is needed. We usually perform a 5 to 6 centimeter approach, descending from the proximal aspect of the tibial tuberosity to the distal aspect of the tibia. We only have to release slightly the MCL and protected it with a Hohmann retractor. To do that, we always elevated it with the periostal elevator to be able to dissect it from the bone. A second window is needed on the lateral side to be able to dissect the tibialis anterior muscle from the lateral part of the tibia and be able to shoot a second Hohmann retractor to protect completely the muscle and the neurovascular structure from the lateral side. This part of the approach is usually done in flexion. Key wire positionings are performed through this window. The first key wire need to be 2 centimeters minimum from the proximal aspect of the tibial tuberosity. The second one will be positioned based on the resection height anticipated on the preoperative X-rays. We usually bend those key wires to be able to easily drive the saw blade inside of the bone without being bothered by them. We then position the plate before cutting, and we've drilled the more proximal hole of the plate to be sure that the position will be perfect in frontal and lateral views before creating the resection wedge when the situation is still very stable. For the cuts, we usually try to cut the key wires to avoid diverging from them. We ascend the saw blade and cool the blade down to be able to optimize the healing process of the bone without burning the bone with the saw. We verify on the X-rays that the cuts are complete, and we then finish the cuts with a chisel, medial and lateral, to feel that the osteotomy is starting to move. When those steps are done and the osteotomy seems ready to be closed, we verify on the X-ray that we don't have any piece of bone or tissue remaining inside of the osteotomy gap. We finish the movement, if needed, with a saw blade inside to clean the debris, activating the saw blade inside, in and out, to remove all the piece of bone and debris that can be inside. To close the gap, we just move the leg to full extension, turning the plate to the pre-cut position that was created using the proximal screws, then going to full extension, applying a little bit of hyperextension to the leg to completely close the osteotomy gap. We usually completely fix the more proximal screws before using this cortical screw that will create the last 2 millimeters of compression using a bicortical cortical screw that will completely compress the plate into this oblong hole. Then we switch to the ACL tunnel, which is the last step of the surgery. We increase the size of the reamer and the drill to be able to feel that the tunnel are complete, not touching the proximal screws of the plate, and make it easy to create a perfect ACL tunnel. Do partial weight bearing for 3 weeks. We use PCL brace with -10 extension for 6 weeks. Return to sport is possible at 10 months and return to work around 2 months post-op. Specific concerns: when hinge fractures happen, they need to be fixed during surgery. In this scenario, for example, an anterior to posterior screw was used after removing the plate. In big resection, more than 15 degree, infratubercle osteotomy will create 2 big resections for the bone, and inverted dome could be used to avoid this problem. Thank you for watching.